If you miss a single painless genital ulcer in your clinic today, you might actually increase your patient's chances of contracting HIV by like 300-fold tonight.
It's wild to think about, but yeah. I mean, in the world of infectious diseases, especially the ones transmitted through intimate contact, the stakes are just incredibly high.
Right. And the diagnostic landscape is, it's often really murky. Patients are asymptomatic. These pathogens are literally hiding inside host cells.
And diseases are just constantly mimicking each other, right? It's a field where you can't just rely on a straightforward X-ray to point at a broken bone.
Yeah, exactly. We'll be breaking down all major concepts covered on the exam. I'm Harvey.
And I'm Donna, and we are your MCCQE reviewers, really dedicated to helping Canadian medical students feel totally comfortable with the exam review process.
Absolutely. Now, just a quick piece of housekeeping before we jump in. This deep dive teaches directly from reliable StatPearls articles.
Right, but we do need to say this is for medical education only, not medical advice. Any actual clinical decisions need to involve a qualified healthcare provider.
For sure. So your mission today, as you prep for the MCCQE, is to basically conquer Section SO7, which is infectious diseases.
Yeah, specifically focusing on sexually transmitted diseases. We're going to distill all those exam-relevant definitions, the classic presentations.
The Canadian management strategies, which are so important.
Yes, and the biological why behind the common clinical traps, because mastering this material really requires recognizing patterns,
It's all about pattern recognition. You can essentially group these infections into two broad clinical buckets. You've got the discharge and dysuria presentations, and then the ulcerative lesions.
Let's start with that first bucket. So a patient walks into your outpatient clinic complaining of a burning sensation when they pee, or, maybe some urethral or vaginal discharge.
Right. The primary pathogen you need to hunt down here is Neisseria gonorrhea. On the exam, they absolutely love to test your microscopy skills.
Oh, they do?
And the classic description for this bug is gram-negative intracellular duplicaci.
Yeah, visually, if you're looking at that gram stain, you'll see what look like tiny red coffee beans pressed together in pairs.
Obvious, right.
But the key word there is intracellular. You will literally see these paired coffee beans sitting inside the host's neutrophils. I mean, they don't just float around in the extracellular space.
No, they actively invade. And
Yeah.
the mechanism it uses to do that is just wild.
It really is.
Neisseria gonorrhea operates like a stealthy hitchhiker. It has these hair-like appendages on its surface called pili.
Right.
And it uses these pili almost like grappling hooks, It shoots them out to attach to the complement receptors on the surface of the human epithelial cell.
Which is just so sneaky. And once it's anchored, it literally manipulates the host cell's cytoskeleton, forcing the cell to swallow the bacteria inside a vacuole.
And by hiding inside that vacuole, the bacteria completely avoids being destroyed by the cell's lysosomes.
It's a brilliant evasion tactic. I mean, it allows the pathogen to quietly ascend the reproductive tract, completely shielded from the immune system.
Yeah.
And this stealth mechanism explains a massive public health challenge, because while over 90% of men will show obvious symptoms,
Like the purulent discharge and severe dysuria.
exactly, but over 50% of women are entirely asymptomatic. The bacteria just sets up camp in the cervical epithelium and multiplies unnoticed.
Wow, over 50%. So since we can't rely on symptoms for half the population, routine screening is basically our only net.
Yeah, it has to be.
And the gold standard for diagnosis here is the NET, right? The nucleic acid amplification test.
Yep, it's highly sensitive because it's really just looking for the genetic footprint of the bacteria. You can run it on an endocervical swab, a vaginal swab, or even just a first catch urine sample.
But when that NET comes back positive, your treatment strategy requires some very specific attention, especially for your Canadian exam prep.
This is a huge point. If you study from American materials, you'll often see a single intramuscular injection of ceftriaxone 500 milligrams as the standalone treatment for gonorrhea.
Right, but the MCCQE tests Canadian guidelines.
Exactly. In Canada, the favored alternative first-line therapy for uncomplicated urogenital gonorrhea is an entirely oral regimen.
Which is nice for the patient. So you give a single dose of oral cefixime 800 milligram paired with a single dose of oral azithromycin 1G.
And there is a mandatory buddy system here. You'd almost never just treat the gonorrhea in isolation, right?
No, because the co-infection rate is so astronomically high. Empiric treatment dictates that you must treat for chlamydia at the exact same time.
Always. You add oral doxycycline 100 milligrams twice a day for 7 days. Well, unless chlamydia has already been explicitly ruled out by a negative NAT, of course.
Right. Now, going back to the bug itself, when that vacuole-riding bacteria isn't stopped at the cervix, it just continues its ascent.
Yeah, it moves up. In men, it travels down the vas deferens and triggers epididymitis. Yeah, and in women, it moves from the cervix up into the uterus and outward into the adnexa, which is just the clinical term for the fallopian tubes and ovaries.
And this ascending threat is what results in pelvic inflammatory disease, or PID.
Right, so on a test stem, the hallmark presentation of PID is usually a sexually active young woman with bilateral lower abdominal pain.
And when you do a pelvic exam, you'll find adnexal tenderness, uterine tenderness, and cervical motion tenderness.
Oh, the classic chandelier sign.
Yes, the last one is famously called the chandelier sign because manipulating the inflamed cervix causes such sharp, exquisite pain that the patient might reflexively reach for the ceiling.
It's awful for the patient. The acute pain is severe, but the long-term complications are what the exam really wants you to understand.
Right, the scarring.
Exactly. The inflammation inside the fallopian tubes destroys the ciliated epithelial cells. So normally these cilia act like millions of microscopic brooms, right? Sweeping the fertilized egg down the tube and into the uterus.
But when those microscopic brooms are destroyed by the infection, the body just replaces them with rigid scar tissue.
Yeah, and that's where the danger lies. The fertilized egg tries to travel down the tube, but it gets physically stuck in the webbing of that scar.
Which is exactly why the risk of an ectopic pregnancy just skyrockets after PID. The sources actually note the ectopic rate jumps to 7.8% post-PID compared to just a 1.3% baseline.
That's a huge jump. And that identical scarring mechanism also blocks sperm from ever reaching the egg, which leads to a 5-fold increase in the risk of permanent infertility.
Wow.
Furthermore, if the infection spills out the open end of the fallopian tubes and into the peritoneal cavity, it can travel all the way up to the liver.
Oh, right, causing inflammation of the liver capsule.
Exactly, resulting in right upper quadrant pain. This is known as Fitzhugh-Curtis syndrome, which is another really high-yield exam favorite.
Wait, I have a question about the diagnostic timeline here because it kind of doesn't make sense clinically. We established that NATs are the gold standard for identifying gonorrhea and chlamydia, right?
Right.
But if a NAT takes hours or even days to process at the lab, are we seriously just sending a woman with severe pelvic pain home with ibuprofen to wait for a phone call?
Oh, no, you absolutely do not wait. This is a common exam trap. PID is primarily a clinical diagnosis.
Okay, that makes sense.
Waiting for a NET result, or even waiting for a pelvic ultrasound, unless you're actively ruling out a surgical emergency like an ectopic pregnancy or a ruptured tubo-ovarian abscess, is a massive clinical error.
Because you're losing time.
Exactly. Delaying broad-spectrum antibiotics directly correlates with the permanent destruction of those fallopian cilia. You diagnose clinically based on the pelvic exam, and you treat empirically on the spot.
And the empiric treatment for PID has to be really aggressive, doesn't it?
Yeah.
Because the infection rarely stays isolated to just gonorrhea and chlamydia.
Yeah, once the cervix is inflamed and open, all the regular vaginal flora just march right up into the upper tract. It becomes a complete polymicrobial party.
Right. So to shut that down in an outpatient setting, you administer a single intramuscular dose of ceftriaxone to cover the gonorrhea.
Plus oral doxycycline for 14 days to clear the chlamydia.
And then you add a 14-day course of oral metronidazole.
Yeah, the metronidazole is specifically required to eradicate the anaerobic bacteria and agents of bacterial vaginosis that have, opportunistically joined the upper tract infection.
Okay, so we've seen how these pathogens cause deep internal damage while ascending completely silently. But what happens when the first sign of trouble isn't a deep pelvic ache, but a visible external breakdown of the mucosal barrier itself?
Ah, yes. That brings us to our second clinical bucket, the genital ulcers.
This is such a challenging differential diagnosis on the MCCQE because multiple organisms cause ulcerative lesions, and they honestly look confusingly similar.
You really do. You need a rapid way to filter the possibilities on exam day.
The best triage strategy for the exam is to basically ask a single question the very moment a genital ulcer appears in the test stem. You just ask, does it hurt?
It's so simple but so effective.
Right. That one question splits your differential instantly. So let's start with the painful side of the flowchart. The classic painful ulcer is chancroid.
Right, which is caused by the bacteria Haemophilus ducreyi.
The pathophysiology of chancroid involves this intense, rapid tissue necrosis. The bacteria produces a toxin that destroys the local epithelial cells so violently that the base of the ulcer essentially turns to mush.
It's pretty brutal, and that's why the clinical description always notes a friable base, the slightest touch with a cotton swab, and it bleeds easily.
Yep, it's heavily inflamed, covered in a yellow-gray exudate, and extremely painful.
And that rapid localized destruction also travels to the draining lymph nodes. Patients frequently develop suppurative buboes in their groin.
Buboes, yeah, those are severely swollen, fluctuant, pus-filled lymph nodes that can actually undergo spontaneous rupture right through the skin.
Which is horrifying. And if they give you a gram-stain description for Haemophilus ducreyi, the buzzword to look for is a school of fish or railroad track appearance. You treat it with azithromycin or ceftriaxone.
Okay, so moving over to the painless side of the triage flowchart, we encounter two major players. The first is Granuloma inguinale, often called donovanosis, which is caused by Klebsiella granulomatis.
Yeah, it's pretty rare in North America, but it is highly testable. It presents as a beefy red, painless ulcer with heaped-up borders that are often described as serpentine or snake-like.
And the microscopic buzzword for donovanosis is Donovan bodies. If you biopsy that beefy red tissue, you will see macrophages that have literally swallowed the bacteria.
Right. And inside the macrophage, the bacteria look exactly like closed safety pins.
So beefy red ulcer, safety pin, Donovan bodies. You choose Granuloma inguinale and treat with a prolonged course of azithromycin.
Exactly. But the undisputed heavy hitter on the painless side of the flowchart is primary syphilis.
Oh, for sure. The initial presentation is the classic chancre. It's a firm, round, indurated, clean-based, completely painless ulcer.
And this circles back to the massive public health risk we mentioned at the start of the deep dive.
Yeah, why is an ulcer that doesn't even hurt
Yeah.
and often just resolves on its own without treatment such a massive deal?
Because any genital ulcer, whether it's painful like chancroid or painless like syphilis, physically breaks the protective mucosal barrier.
Right.
During an unprotected sexual encounter, an active ulcer acts as a direct open doorway into the bloodstream. This physiological reality makes ulcers a massive cofactor for HIV transmission.
Increasing a patient's susceptibility by like 50 to 300-fold, like we said earlier?
It is a strict clinical rule.
Yeah.
You must always test ulcer patients for HIV.
Always. And if that painless chancre is caused by Treponema pallidum, the bacteria responsible for syphilis, the danger goes far beyond HIV susceptibility.
Yeah, syphilis is famously known as the great imitator.
If you miss that initial painless ulcer, which, is incredibly easy to do if it's located internally on the cervix or the anal canal, the spirochete disseminates through the blood and just mimics countless other diseases across its stages.
Yeah, so once the primary chancre heals on its own, which gives the patient a total false sense of security, by the way, the disease enters the secondary stage weeks to months later.
Because the bacteria has now spread systemically.
Exactly. The hallmark exam finding here is a diffuse maculopapular rash that crucially involves the palms of the hands and the soles of the feet.
Which is a massive diagnostic clue, because most typical rashes spare the palms and soles.
Right. Secondary syphilis also manifests with condyloma lata. These are highly contagious, flat-topped, moist lesions found in the genital area.
And you have to contrast those with condyloma acuminata, which are the spiky, cauliflower-like genital warts caused by HPV.
Right. Lata is flat, acuminata is spiky. So following the secondary stage, the spirochetes go dormant in the latent phase. If the patient remains untreated for years or even decades, the immune system's chronic, smoldering attempt to clear the bacteria results in tertiary syphilis.
And this stage is defined by just catastrophic structural damage.
A prime example is cardiovascular syphilis. The bacteria actually attacks the vasa vasorum.
Those are the tiny blood vessels that supply oxygen to the walls of the aorta itself, right?
Exactly. The resulting inflammation destroys the elastic tissue of the aorta, leading to massive ascending aortic aneurysms. On an autopsy or imaging description, the inside of the damaged aorta is said to have a wrinkled tree bark appearance.
Tertiary syphilis also features the formation of gummas. These are destructive, necrotic granulomas, essentially walls of immune cells trapping dead tissue that can carve out space in the skin, the liver, the bones, or the palate.
It's devastating. And then there's neurosyphilis. The critical concept for the exam here is that neurosyphilis is not strictly a late-stage complication.
That's a great point. It can happen at any stage.
Yep. Early on, it might present as acute meningitis or a stroke. Years later, it manifests as Tabes dorsalis.
Tabes dorsalis is the physical demyelination of the posterior columns of the spinal cord. And since the posterior columns carry proprioception, which is your brain's ability to know where your body parts are in space,
When those tracts are destroyed, the patient literally doesn't know where their feet are without looking down at them.
which results in that classic, stomping, wide-based sensory ataxia gait.
To definitively diagnose neurosyphilis, you have to perform a lumbar puncture and look for a positive VDRL test in the cerebrospinal fluid. If it's positive, the treatment is exclusively IV aqueous penicillin G.
Okay, but the broader diagnostic logic for syphilis in the blood often leaves students really tangled up.
Oh, constantly.
There are two categories of blood tests, right? Non-troponemal tests like the RPR and VDRL, and troponemal tests like the FTA-ABS. If a patient comes in and has a positive troponemal test like the FTA-ABS, how do we actually know if they have an active infection right now, or if they just had syphilis 10 years ago and were cured?
That is the perfect question, and the distinction comes down to what you are actually measuring. So the troponemal test, the FTA-ABS, looks for specific antibodies created directly against the Treponema pallidum bacteria. Once your immune system learns to make those specific antibodies, it never forgets. Therefore, the troponemal test acts as the scar.
A scar, I like that.
Yeah, it tells you that at some point in your life you were infected. It will be positive for life, even after you are completely cured.
Ah, so the non-troponemal tests, the RPR and VDRL, those are completely different. They're the thermometer.
Exactly. But why? Because they don't look for the bacteria at all. When the spirochete destroys your cells, your cellular mitochondrial membranes burst open, releasing a lipid called cardiolipin into the bloodstream.
And your immune system sees this floating debris and makes antibodies against the cardiolipin.
Right. That mechanism is why the RPR acts as a thermometer for active disease. If the syphilis is highly active and destroying lots of tissue, cardiolipin levels spike, and the RPR titer goes way up.
And when you successfully treat the patient with penicillin, the destruction stops, the cardiolipin clears out, and the RPR titer falls dramatically.
Exactly. So to definitively diagnose an active infection, you need both. The FTA-ABS scar to prove it's truly syphilis, and a high RPR thermometer reading to prove active cellular damage is occurring right now.
Let's apply this to a high-yield clinical trap. You have a pregnant patient who tests positive on both the scar and the thermometer. She has active syphilis. But she tells you she has a severe anaphylactic allergy to penicillin. Can we just use an alternative antibiotic like doxycycline?
Absolutely not. This is a non-negotiable rule on the MCCQE. For a pregnant woman with syphilis, penicillin G is the only acceptable drug.
Because doxycycline inhibits bone growth and discolors teeth in the developing fetus, making it strictly contraindicated in pregnancy.
Right, and other alternative antibiotics just do not reliably cross the placenta in high enough concentrations to treat the fetal infection.
So if she's allergic, you have no choice. You admit her to the hospital, run a careful desensitization protocol to temporarily bypass her allergy, and then you administer the penicillin.
You have to protect the fetus from congenital syphilis at all costs. Untreated, the spirochete crosses the placenta and causes devastating outcomes. Stillbirths, severe fetal edema known as hydrops fetalis, and late manifestations like saddle nose deformities, saber shins, and Hutchinson teeth.
Hutchinson teeth are those notched, peg-shaped front teeth.
Yep, that's them. And when you do administer that penicillin, you must prepare the patient for the Jarisch-Herxheimer reaction.
Oh, this is a big one. Penicillin works by breaking open the bacterial cell wall. So within 24 hours of that shot, millions of spirochetes burst apart simultaneously, just flooding the bloodstream with bacterial endotoxins.
And the patient's immune system will mount a massive, sudden inflammatory response. They'll develop a high fever, chills, and severe muscle aches.
You have to counsel them beforehand so they understand it's a normal physiological response to the dying bacteria, not a sudden allergic reaction to the medication.
Right, that distinction is crucial.
Okay, to round out our exploration of urogenital pathogens today, we need to look at an infection that mimics the symptoms of an STI, but isn't actually a sexually transmitted disease. It's an opportunistic shift. Candidiasis.
Yes, candidiasis is primarily caused by Candida albicans. This is a normal, harmless component of human flora. It lives quietly in the mouth, the gut, and the vagina.
It doesn't cause problems because it is constantly kept in check by the local environment, specifically by healthy acid-producing bacteria like lactobacillus.
But the clinical picture changes the moment that environment is disrupted. Say your patient takes a course of broad-spectrum antibiotics for a respiratory infection.
The antibiotic indiscriminately wipes out the protective lactobacillus.
Exactly. Or, the patient has uncontrolled diabetes, flooding their mucosal secretions with excess glucose. Suddenly, the Candida has zero competition and unlimited food, so it overgrows rapidly.
In the vaginal environment, this overgrowth triggers intense vulvar itching, burning, and a classic, thick, white cottage cheese-like discharge.
And in the oral cavity, we call the overgrowth thrush. It presents as thick, pseudomembranous white patches towards the tongue and buccal mucosa.
The definitive exam feature is that if you use a tongue depressor to scrape those white patches off, it leaves a bright red, erythematous, bleeding base underneath.
Clinical context is everything with oral thrush, though. Seeing it in an infant with an immature immune system or an elderly patient whose dentures alter their oral flora is, relatively routine.
However, if a healthy-looking 25-year-old adult presents with oral thrush, it is a glaring red flag for severe cellular immunosuppression. You must urgently test that patient for HIV.
Absolutely. Now, the treatment for candidiasis typically involves topical antifungal creams or a highly convenient single oral pill. Fluconazole 150 milligram.
We love an easy one-time pill like fluconazole, but isn't there a major population we have to withhold that from?
Yes, that easy one-time oral pill is strictly forbidden in the first trimester of pregnancy.
It comes down to the mechanism of action, right? Systemic azole antifungals like fluconazole work by inhibiting the sterile synthesis pathways that the fungi use to build their cell walls.
Right. However, early in the first trimester, the developing human embryo relies on those exact same biochemical sterile pathways to build craniofacial structures and skeletal bones.
So shutting down that pathway with oral fluconazole can cause severe skeletal birth defects.
Exactly. For pregnant patients suffering from a yeast infection, you must restrict treatment entirely to localized topical antifungal creams.
Okay, let's bring all these concepts home for your MCCQE prep. If you suspect gonorrhea or chlamydia based on discharge, you treat empirically for both.
In Canada, that specifically means oral cefixime and erythromycin for the gonorrhea, plus doxycycline for the chlamydia.
And PID is a clinical diagnosis triggered by ascending pathogens destroying fallopian cilia. Do not delay broad-spectrum antibiotics waiting for lab results, or you actively risk your patient's future fertility.
Right. When faced with a genital ulcer, triage by asking, does it hurt? A painful, friable ulcer is chancroid. A painless ulcer points to Granuloma inguinale, or the chancre of primary syphilis.
For syphilis serology, the troponemal FTA-ABS test is the permanent scar of infection, while the non-troponemal RPR test measures cardiolipin to act as a thermometer for active tissue damage.
And if a pregnant patient has syphilis alongside a penicillin allergy, desensitization is mandatory. Penicillin is the only option.
Mastering these facts isn't just about clicking the right multiple-choice option on exam day. The sources note a massive exponential rise in congenital syphilis over the last decade.
It's really tragic. It's a devastating disease that is 98% preventable with a single shot of penicillin.
Ponder what this means for your future clinical practice. You aren't just memorizing pathways. You are preparing to stand on the front lines of a resurging, entirely preventable public health crisis.
Exactly.
By understanding the biology of these pathogens, recognizing that single painless ulcer in your clinic can quite literally save 2 lives at once.